All right.
Okay, thank you very much. Okay, so good morning, everyone. Um, I hope you all had a nice weekend. We really miss you in the college. So today's lecture will be on EEG and seizures. Very briefly on seizures. So the first part of the lecture will be mainly on EEG. We'll talk about the physiological basis of the EEG signal, the different waves and rhythm. We will also look at some examples of EEG, normal EEG versus abnormal EEG records. We will briefly, also talk about, seizures. Okay. Okay. Now, so let's let's firstly explore some history here. So the first ever documented, or evidence of for the existence of some electrical potentials from the brain was documented in the 1875 by a professor of physiology. His name is Richard Caton. He basically indicated or documented the existence of some electrical potentials coming from the brains of live animals. Okay. Then subsequent work done by Adolf Beck, who basically used to experiments with dogs, where he placed electrodes directly on the surface of their brains to detect, brain electric field potentials. And he showed that by directing light to the eyes of the dog, he was able to observe, large electrical potentials coming from, the brain. Okay. Then in 1924, this is the significant, date for the when it comes to the EEG, where Hans Berger, who was, considered the father of this technique, showed or described for the first time the alpha wave, which you will learn about in the upcoming slides. It's a 10 hertz type of wave, which we will learn about in a second, which is a wave that is more prominent in awake individuals who are relaxed and have their eyes closed. Okay, so he was Hans Berger. He was the first guy to document electrical fields from humans. Okay, this guy, Hans Berger. And he is the one who gave it the name electroencephalogram, which stands for, EEG stands for electroencephalogram. Okay. So this is just, some history. As you can see here, this is the alpha wave here compared to a 10 hertz time signal. Okay, we will learn about this in a second. Now, what is EEG? Basically, EEG is a non-invasive tool, okay, which is used to measure the electrical activity from the surface of the skull. Okay, as you can see here. So we have metal discs. So these are electrodes, okay, placed on the surface of the head. And these are connected to a board or a monitor to detect and record the signals. Okay. EEG is mainly used for diagnosis of epilepsy, so it's very commonly used for this purpose. Also coma and brain death. In rural areas where there are lack of fancy imaging equipments like the MRI or CT scan, also EEG can be used to diagnose other disorders of the brain, like stroke or tumors, migraine, encephalitis, etc. But mainly has been used in clinical settings for diagnosis of epilepsy, coma, and brain death. Okay, so let's talk about the technique itself. There is a lot of details, but this is what you need to know is more about the principles, okay? So the way that the electrodes are placed on the head is not random. They follow a system called the 10 to 20 system, where basically they measure the distance from the nasien here to the prominent bone here on the back of head, which is called the inion. Okay, so they measure the distance medially. Okay, and then electrodes are placed with a distance of 10 to 20% relative to the distance medially from the nasien to the anion. Okay, so as you can see here, so this is the looking from above, this is the head, and so medially going from here to here, okay, or coronally from here to here, okay. So the way and each of these electrodes, so the letters here stands, for example, F is for frontal, Z for zero, okay. C is central, P parietal, C, as I said, central, T temporal, and O occipital, and A stands for the earlobes, okay. Now, if you noticed that on this side, this is the left side, okay, and this is the right side, right? So the odds number are of the electrodes are placed on the left, okay, whereas the even numbers like 2, 8, 4, okay, are placed on the right side. So this is the left, this is the right, okay. Now, the way that the signal gets detected follows what's called differential, amplification, where basically the output is the difference between two inputs. Okay, so for example, so we can see this is input one. This is the signal, and this is from the another electrode. So this is the signal. Now the output is the difference between the two. So this is the difference. So this facilitates the removal of the background noise to get more meaningful information. Okay, and because the signal is so small, which is in microvolt ranges, the signal gets amplified. Okay. Now, there are two ways in doing the differential, recording or systems of recording. There is the referential montage, so they call it montage, the way they record. So this is referential montage here, and this is the bipolar montage. If you notice that in the referential montage, the signal, so this is signal one, is the difference between the electrode from each of these electrodes on the head in reference to the electrode placed on the ears. Okay, so we don't expect signals coming from the ear loops, and so all of these electrodes here, okay, placed on the head, the signal from these are relative, or the difference from each relative to the electrode placed on the earlobes. And so the referential montage is meaningful to give an overview of the generalized activities of the electrical field activities of the brain. okay? Whereas here, the bipolar montage, the signals are the difference, the output is the difference between adjacent electrodes, as you can see. So one is between, the difference between F1 and F7. Two is the difference between F7 and T3, etc. Okay, and this type of montage, the bipolar montage, is very useful for to give more precise information about local changes. Okay, so this is in the technique itself. So this is just a video if you would like to learn more about the technique. Okay. So what are the type of signals that we get on the EEG? So this is, you can see, so this is a 1 second here, 0 to 1. So this is 1 second, and here the amplitude is in the microvolt ranges. Okay, so different waves, from the EEG have been classified mainly based on frequency. Okay, so based on frequency, so there is the delta wave, okay, which is the least, which has the least frequency. It has frequency of 4 hertz. Okay, so 4 hertz is 4 wave, or 4 waves per second. Okay, so you can see here. So this is 1, 2, 3. So around up to 4 hertz is basically is called the delta wave. The theta wave comes in the ranges of 4 to 7 hertz. There is the alpha wave, which we mentioned in the beginning of the lecture, which was the first to be discovered. This has the frequency of 7 to 13 hertz. The Mo waves similarly, but has different amplitude. The beta waves is around 14 to 30 hertz, okay, more frequent. And we have the gamma wave, which has the the highest frequency. Now we will learn about, so each wave is associated with a different, physiological behavior, as we will see in a second. So this is just to show you the different signals that can be detected on the EEG, and they have been classified based on frequency. Okay, everything is good so far. So we'll get into the questions at the end. Okay, so this is just to show you. You don't need to like memorize this. You need to know the different waves, of course. But I mean, the way you interpret the recording, you don't need to know this. You are not expert, neither I am. But this is just to show you how it's done. So as we learned that the odd numbers represent the left side of the brain. So this is the left side, this is the right side. And so the recording from one electrode or an output is the difference between two inputs, as we said, okay? And so this is across time, so as you can see, so each square represents 1 second. Okay, so 0 to 1, 1 to 2, 2 to 3. And in this example here, we can see the alpha wave, which we said is, it's the alpha wave is basically has a frequency of 7 to 13 hertz. Okay, so we can see the alpha waves, on different electrodes, which we said the alpha wave is more prominent in rested individuals who are awake. Okay, they are not asleep, they are awake, but they are rested, relaxed, and have their eyes closed. And as you can see, when they open their eyes, the alpha waves disappear. Okay, and it gets back again when they have their eyes closed. Okay. Now, we know that the EEG detects some sort of a rhythm or a signal, but what is it exactly, the signal that being detected on the EEG? Okay, so we already learned in the previous lectures about action potential, postsynaptic potentials, etc., synaptic neurotransmission, and all of these concepts and how the neurons communicate with each other. So what is it that we are recording on the EEG? Uh, what they have been suggested is that what EEG actually measures is the postsynaptic potentials rather than action potentials, okay? So the reason for this is because the action potential, as we learned, is very fast, okay? Whereas postsynaptic potentials, they are more flexible in terms that they can submit, and they can be summoned, both temporally and spatially. Okay, and so this is why they scientists or generally speculate that what have what is recorded on the EEG is the postsynaptic potential rather than action potential. This is regarding the normal EEG waves. However, some speculate that with, for example, the EEG signals that we record in epilepsy, also we are detecting action potentials, because in epilepsy or seizures, there is the vigorous synchronized activities of the neurons, and so we do detect action potentials from on EEG from people experiencing seizures, etc. But with normal waves, generally what contributes into the EEG signals is mainly the postsynaptic potential, including both the excitatory as well as the inhibitory postsynaptic potentials, as we will see now. Now, the EEG signal that gets detected is basically the source of these signals are the pyramidal neurons and the thalamocortical neurons. Okay, so here we have the electrode placed on the surface of the head, and we know that the cortex is the outer layer of the brain, which consists of 6 layers. So 1, 2, 3, 4, 5, 6. So 6 layers of the cortex here. And what is believed to be the source of the EEG signal is the pyramidal neurons. So these are the pyramidal neurons, okay, which have their dendrites extended, to the towards the surface of the head, okay, and so these pyramidal neurons lies vertically. Okay, so you can see they are vertical. Communicating with these pyramidal neurons is the thalamocortical neurons. So as you can see here, they are synapsing. These coming from the thalamus, the thalamocortical neurons. Now, what contributes into the EEG signal is believed to be the communication between the thalamocortical neurons with these pyramidal neurons. Okay, so we learned this, that these will communicate, the thalamocortical neurons will synapse with the pyramidal neurons, okay, and they will communicate by release of neurotransmitters to try to depolarize or hyperpolarize the pyramidal neurons, okay. So now from the when they are communicating, we know that the opening of the ligand-gated ion channels, okay, if it was excitatory, this would lead to the influx of sodium, right? So sodium entry into the pyramidal neurons will make the inside of the cell less negative, okay? And at the same time, the local site around where the synaptic communication is happening, okay, will be gaining more negativity, as you can see here, okay? Because we are losing sodium as sodium going to the inside, so the outside becomes a little bit negative. With further away from this side, still intact, as we have positive, okay? And so having a negative negativity around the site where the synaptic connection is happening, and this positive positivity create what's called a dipole or an electrical field potential, which essentially what gets detected on the by the electrode. Okay, so this electrical field that gets detected by the electrode. Okay, now so the major source of the EEG signal is the postsynaptic potential, okay? And the type of neurons is the basically the communication between the thalamocortical neurons and the pyramidal neurons, which create this electrical field potential that gets detected by the electrode. Now, there are multiple factors that determine the detection and characteristics of the EEG waveforms. As you just learned, that mainly what gets detected by the electrode is the electrical field that is coming or generated by the communication of the thalamocortical neurons with these pyramidal neurons that lie vertically. And so the reason why this is the major source for the EEG signal, it's because it's very close to the scalp, and so this is why the electrode can detect this electrical field. However, electrical fields that gets generated in deeper areas of the brain cannot be detected by the electrode. Okay, so the distance of the recording electrode from the electrical field getting that is being generated is a major factor. Also, the way the pyramidal neurons are organized in the cortical layer is important. Okay, so for example, if you look at this here, so in the sulci, of the brain, we have the pyramidal neurons lying horizontally rather than, vertically. Okay, and so as you can see that the electrical field being generated, the negative and the positive, is not as close to these ones, to the electrode. Okay, so you can see like in region 2 and 3, the electrical field is very close to the surface of the head. Therefore, it can be detected by the electrode, whereas in area 4 and 1, it's very difficult to be detected by the electrode. So the anatomical organization of the pyramidal cells is very, also play a role in whether, the signal will be detected or not. Now, a major factor, that contribute into the EEG signal, as we know that the EEG signal has, a characteristic of being a rhythm-like signal. And so the major, player is the duration and the number of synchronously activated postsynaptic potential. What do we mean by this? What do we mean by this is the following. So when we have many neurons active at the same time. So these are the pyramidal neurons receiving input from the thalamocortical neurons. And so when these are creating postsynaptic potential, okay, that is, happening in the same time, this will be detected on the EEG as a large amplitude. Okay, so the more synchronous the activities, so you can see the more synchronous the activities of the neurons, okay, or the postsynaptic potential, the large the amplitude of the signal. Whereas the less synchronous the activities, from different neurons, this will be having less amplitude. So this is very obvious in this image here. So you can see those, these are single events from different neurons, okay? And as you can see here, that these are being detected, at the same time, okay? So they are synchronous, and so this will be detected on the EEG as having a large amplitude signal, okay? Whereas less synchronous, as in orange, okay, will be detected as having a less amplitude waves, okay? Now, why the EEG has rhythms, okay? Why does it produce rhythms? It's because of these thalamocortical neurons, okay? So these thalamocortical neurons communicate with the pyramidal neurons in a synchronous way, okay? And so this is why the rhythms that the electrode, okay, detects rhythms, okay. So these thalamocortical neurons, as you can hear, so these thalamocortical neurons have intrinsic oscillatory properties, okay, and supporting these thalamocortical neurons in generating in generating oscillations is these thalamic reticular neurons. These are GABAergic, as you can see here, and is believed to act as a pacemaker by releasing GABA in a rhythmic bursts. Okay, so they stabilize the bursting activities or the synchronization of the thalamocortical neurons, and so by generating postsynaptic potent by communicating with the pyramidal neurons in a synchronous way, this will be detected by the EEG signal as rhythms, and depending, on the way these are being synchronized. If they are very well, being very well synchronized, as in the delta wave here, this is very well manifested on the delta wave, where the waves has very large amplitude. Okay, and we will learn this in the sleep lecture. So delta waves has very large amplitude, and this reflects that the thalamocortical neurons are communicating with the pyramidal neurons, okay? And the postsynaptic potential that's being generated is very synchronized, okay? And so this will be detected by the electrode as having very large waves, okay? Now let's, so we know the, physiological basis of the EEG waves. Now let's look at the, what do these waves, represent. So as we said, that waves, the EEG rhythms have been mainly classified based on frequency, but as equally important is the amplitude, the shape of the signal, where it has been detected. Is it on, frontal, or is it occipital, is it parietal, and whether the signal is, reactive. Like for example, with the alpha wave, that has a reactivity to either, to opening the eyes. Okay. Also, to give the wave or the signal a meaning, we have to also take into consideration the age of the subject. For example, there are waves where they are normal when they are detected in kids, but they are abnormal if the same wave was seen in adults, okay? Or, you know, in awake adults, for example. And so also the state, whether, you know, it's asleep or awake, okay? And also the use of psychotropic drugs, okay? So we have to take these into consideration when we interpret the signal. So as we learned that the delta wave has the less frequency of zero point 0.1 to 3.5 hertz, but they have very large amplitude. You can see it's 50 to 350 microvolt, okay? The theta wave also is on the lower frequency ranges from 4 to 7.5 hertz, very small amplitude. The alpha wave has around 8 to 13 hertz, you know, of higher frequency ranges. Beta wave above 13 hertz, okay? The Mo wave is around 7 to 12 hertz. However, the amplitude, so this is very similar to the alpha, but the amplitude is much less, you know, compared to the alpha waves, okay? So what do these waves, you know, indicate? So the alpha wave, which we said this is the first wave to be discovered, and as we learned, this has a frequency of 8 to 13 hertz, mostly recorded in the parieto-occipital area and mainly prominent in awake, relaxed individuals with their eyes closed, okay? And can be detected in multiple electrodes, and they disappear with eyes opened, okay? So they are reactive to opening the eye. So this is the alpha wave. The beta waves, they have a frequency of 13 to 30 hertz, okay? And they can be detected in different electrodes, and they basically are mainly found in individuals who are preoccupied with, or, you know, who are awake and they are engaged in a task, in a mental task. Like you guys, hopefully, if we are taking your EEG recording right now, you probably most likely have the uh, beta waves. I hope so. Okay, you are not asleep. However, if you are asleep, you, especially if you are, you know, experiencing drowsiness, you would be, you know, showing the theta waves, which has, you know, more of the less frequency ranges of 4 to 7 hertz. It's normal, so finds for so this theta waves detected in children, awake children, that's normal, okay, and sleeping adults, okay. But if the awake adults is showing the theta waves, then this indicates some sort of brain disorder, okay. Now, the slowest of them all is the delta waves, okay, which has the large amplitude, if you remember, okay. So these delta waves, they have the slowest, they are the slowest, and they have frequency of 0.5 to 4 hertz. These delta waves, as we will learn in the sleep lecture, they are more prominent in individuals who are experiencing the very deep stage of sleep, as we will learn, okay? And also can be detected in infants when they are, you know, awake infants, okay? When a awake individual shows the delta waves, then this indicates very serious brain damage, okay? Now I hope this is all clear. Okay, good. Now, the second part of the lecture is on the seizures and epilepsy. Okay, very briefly, you will learn more about different types of seizures because this is a very big topic, by clinicians. But this is just to give you a glimpse into, seizures. Okay, so what is a seizure? A seizure is basically the most extreme form of synchronous brain activity, which basically means a group of neurons that are experiencing a pathology where they are firing vigorously in a synchronous way. Okay, and can be classified into a generalized seizure where the seizure involves the entire cerebral cortex of both hemispheres, as in this case. So this is a generalized seizure. So the EEG signal would show, an epilepsy form signals, which we will learn in a second, across all electrodes. Okay, so as you can see, this is generalized, whereas a partial seizure involves only a focal area, okay, more focused, or restricted to a certain area of the brain. Okay, so you can see this is a partial seizure, and the EEG would be the epilepsy form. As you can see, the vigorous waves are detected on some electrodes, while other electrodes are, intact, recording a normal signal. Okay. When a person experiences repeated seizure, this condition is called epilepsy. We'll learn more. There is a lot more details, which you will learn more in the clinical lectures, I think, this week. Now, the etiology and pathophysiology, it's a complicated topic, but it could be the seizure. The cause of seizures could be genetics, or it could be secondary to some trauma, as we learned in the previous PPL. Okay, for example, tumors could induce seizures. Now, the genes that have been implicated in epilepsy includes mutations in genes that encode voltage-gated ion channels. Okay, like many mutations have been found in sodium voltage-gated channels, potassium channels, calcium channels, etc. And the underlying mechanisms of some seizures, some hypotheses suggest, or is thought to be related to the upset of the balance of the synaptic excitation and inhibition in the brain. Okay, so this is why drugs usually used to treat seizure is basically enhances the inhibitory effect, or reduce the excitatory effect. Okay. Now, this is just to give you some examples of some of the seizures. Okay, we said it could be either generalized or partial. An example of the generalized seizures is the primary generalized seizures. These are examples include the generalized tonic-clonic seizure, where these individuals experience loss of consciousness, so they lose their consciousness, awareness, okay, and wakefulness. And this includes also tensing of the muscles, okay, and this is why it's called tonic, and also clonic, as they experience jerking of movements. Okay, so the seizure may last for a few minutes, and usually when they wake up, the individual is basically confused. Okay, so here are some videos for you to see, what generalized tonic-clonic look like. Now, another example of the primary generalized seizure is the absence seizure. The absence seizure is basically more prominent in children or in teenagers. So the absence seizure includes loss of consciousness, okay, which is very brief, but this doesn't involve body movements. Okay, usually the person doesn't change position. Signs include having a blank stare, blink rapidly, make chewing movements, or move an arm or leg rhythmically. Okay, so this is called absence seizure. Examples of the partial seizures include the simple partial seizure. Usually the person remains awake and aware, so this doesn't involve loss of consciousness. Okay, and it depends where the seizure is, in which part of the brain. The individual may experience jerking of movements or experience of abnormal smells, sounds, or changes in vision, nausea, or emotional symptoms. Okay, so this is called simple partial seizure. And there is another example is the complex partial seizure, where the individual may seem to be aware, so there is some partial loss of awareness, but there is definitely irresponsiveness. And so signs include having blank stare, making chewing or lip smacking, repetitive movements of the hand, unusual behaviors like roaming around the place. And after the seizure, the person has no memory of the episode. So these are a few examples of the seizures. Okay. Now let's look at some abnormal EEG waves. So we already learned about the normal EEG waves. What do they look like? Let's learn about abnormal EEG waves. Okay, so this is very obvious, okay, as you can see. So this recording here, we can see that we are detecting, large waves, okay, very large wave, which are indicative of, or they are called epileptiform waves. In some electrodes, in this recording here, you can see that these waves are, detected across all electrodes. And so, in this here is this on the left, the recording on the left, basically is likely to be the recording from an individual who's experiencing a partial seizure, whereas on the right is more likely to be the recordings of an individual who is experiencing a generalized seizure. Okay. As I said, I don't expect you to interpret these recordings. This is just to show you how the abnormal waves look like. Okay, but you need to notice that the waves of an epileptiform wave or a seizure waves typically have large amplitude, and they come in a frequency of 2 to 30 hertz. Okay, so this is what a seizure wave look like. And when interpreting the EEG waves, you have to be very careful, because there are many artifacts. These EEG electrodes are very sensitive, for example, to wet skin. Okay, as you can see, wet skin can induce artifacts, when the individual is sweating, okay, or even light switch. When you switch light in the room, can induce artifacts, as you can see here. Moving muscles, okay, muscle activity can induce artifacts. So you have to be very careful, as these EEG electrodes are very sensitive. and artifacts can be induced easily. Now, not always the having the large and synchronous wave, the crazy waves that are indicative of a lesion, a brain lesion. Also, EEG slowing is considered a problem. Okay, can be a sign of a brain disorder. For example, as we know that we expect in awake individuals to have, the beta or alpha waves, okay, which comes in a frequency, of 8 to 13 hertz in terms of alpha, and the beta waves is more than this. And so when there is, in an awake individuals, we can, if we saw like a theta wave, we're detecting theta waves, which are on the lower frequency ranges. This may indicate a lesion, and lesions including like tumors or migraine, or inflammation, etc. And so this is just an example of an individual showing a temporal parietal slowing, so on these electrodes, okay, showing slowing of waves, okay, as the book indicates, and this individual is experiencing an acute migraine attack. Okay, so the main point here in this slide is to highlight that EEG slowing or slow waves in awake individuals can be a sign of brain disorder. Okay, so this is the end of the lecture. Any questions? Any questions?
Good morning, doctor.
Good morning. Yeah.
Can you explain the referential montage again?
Okay, cool. So let's go to the referential montage. So, okay, so this is just to show you the technique, and there are different ways of sorry. Okay. Okay, so this is just to show you the different ways, different systems of recordings. So there is the referential montage and the bipolar montage. So on the left here is the referential montage, okay? And the way, as we learned, that an output is basically the difference from two inputs, okay? And so in this case, all the electrodes on the left side, okay, are compared to the input coming from the electrode on the ear lobe, because we don't expect to detect any signals in the ear lobes, okay? So in this case, the activities or the input from each of these electrodes will be, will be subtracted from the input that's coming from the earlobes. And so we're not gonna subtract too much information, because we are not gonna detect much activities on the earlobe. Okay, so this is why the referential montage is useful to provide more generalized overview of the activities of the brain in general. Whereas in the bipolar montage, the signal or the output is the difference between the two adjacent electrodes. Okay, so we are subtracting a lot of background to indicate a more precise changes happening in local areas. Okay, so provide more information about more useful to provide information on local changes. Okay, is this clear?
Thank you, doctor. Yes.
Okay, good. Any other questions, guys? Okay, so we can take a break then. So let's see. Somebody slide again 30. Okay, so let's go to slide 30. Which one is slide 30? Oops. Sorry. Slide 30. Which one is slide 30? Sorry, which one?
The one with the two pictures interpreting the two EEG waves.
Oh yeah. Okay.
Yeah.
Okay. Is this okay? I don't know why these. Anyway, so this is just to show you that. So these are two different recordings. Okay. Okay. So. Okay. So these are different recordings from two individuals. And as you can see that in here, it's very obvious that the epilepsy form are being detected on some electrodes, right? Okay. Whereas in here, that the epilepsy form are being detected, as you can see that there is synchronization, okay? So you can see this is very obvious. Okay, so these epilepsy form are, detected across all electrodes, right? So this is most likely a recording of an individual who is experiencing generalized seizure. As we learned that generalized seizures affect or involves the both hemispheres, right? Whereas with the partial seizure, it involves only or restricted to a very specific area of the brain. And so this is why this recording here on the right, okay, this one, as you can see that the epilepsy form is being detected across all electrodes. So this is likely to be indicative of a generalized seizure, whereas in this, in the left, it's mainly a partial seizure. Okay.
Okay, thank you so much, Doctor.
That's okay. Okay. We can use the other link. So I'll stop this and we will be back in 5 minutes. Okay, so you guys take a